Peace be upon you and God's mercy and blessings. Welcome. We will continue the respiratory support series. Last time we talked about a very important classification for each type of respiratory support. And we talked about normal respiration, because by understanding normal respiration, we can more effectively figure out how to classify respiratory support. This time, we will go through each machine, understand what it is, how it works, and which machines can be used with patients in clinical practice. The second thing I want to tell you about are two very important machines, the bubble CPAP and the second one, the high-flow nasal cannula. Let's continue the series on respiratory support because it's one of the most important topics that every pediatrician or neonatologist must understand well. Welcome. The very first thing I want to talk about today is the concept of abbreviation. The abbreviation that we have used here is actually our own, created specifically for this purpose. You might sometimes find a similar kind of abbreviation in short writings, but it's not exactly the same as the one we used. We actually created this particular abbreviation ourselves. It's tailored for every type of user. This is just to clarify. So we respect the rights of those who worked on the classification and those who contributed to it. At the end, I will tell you about something very important called the interface. The interface is the part that is applied to patients to provide internet-based assistance. But I will tell you about it after talking about the machines first. Some of you might ask, what is the Fabosirmi? Because we see it, and to understand the Bahioserum, we need to know something extremely important. It's very important to remember, know, and understand it. The first thing is that when you apply any type of respiratory support to the patient, you must have a very clear statement. Any respiratory support you provide to the patient is essential. Respiratory support is necessary. Whatever the machine is, and whatever its category or type, it must have three very important things. The first thing it absolutely must have is a heater in order to make the air suitable for the right temperature. Secondly, there should be a humidifier to make the air suitable for inhalation, because if you give it without one, the dry air will cause problems for the mucous membranes and the cilia present in the airways. So you should never give a patient respiratory support with any machine without these considerations. Thirdly, it is very important to carefully set the flow rate. Setting the flow rate means that, for the sake of the patient's air, you must determine the most appropriate and suitable flow. This is what we call FiO2. We need to do titration, meaning we either decrease or increase the flow rate. We can start at 21, which is room air, but we can increase it to 30, 40, 50, or even up to 100. However, this titration must be linked to something called target saturation. What is target saturation? It is the saturation level you want to achieve for the patient. In general, if we talk about the normal range for everyone, it is from 90 to 95, but there are other individuals. Their target saturation might be lower than this, such as in congenital heart disease. It could be above 80 or above 75, so you can't just add more oxygen. Or in some cases, for example, in patients with PPHN, you need to add more oxygen because this helps. So whatever target saturation you want for the patient is related to the FiO2, and you can increase or decrease it through the oxygen. These three are the most important things that must be present in any machine. Any machine should have these three. We say this because the Vapotherm is a nasal cannula machine. What does it mean to be a nasal cannula machine? It means it delivers flow to the patient, this flow. As we mentioned, in neonates, it ranges from 1 liter up to 8 liters, and in pediatrics, it's 2 liters per kilogram per minute. This is the flow that comes out. So what's the story with the Vapotherm? The Vapotherm, it has a system that allows for the adjustment of both humidity and oxygen temperature, which is a very important feature. This is because we use it for patients who need oxygen therapy for a long period of time, such as those who are ill and require ongoing support. By being able to control the humidity and temperature, the system helps ensure that patients remain comfortable and safe during their treatment, especially when they depend on it for extended durations. For example, we can give a patient a nasal cannula flow for a week or even months. So it's essential that we use a machine with this capability, one that works well and has good features, making it worth using. A flow of 5, 6, 7, or 8 for these problems The system must work extremely well and reliably for a long period of time with patients because, as we have said, any defect or malfunction in the humidification process or the heater can potentially cause problems because the air entering the patient would be very harmful and could cause respiratory system issues, and we would end up harming the patient more than helping them. As for the microflow, it is a type of machine that we commonly use whenever we need to deliver a flow of less than 1 liter. It starts from 0.8 and goes down to as little as 0.02. So it comes in different grades. But you need to understand something important about the machine. It is connected to the flow, and the flow itself has grades, as we mentioned. 0.8, 0.6, 0.5, 4, 3, down to 0.1, and then it continues to 0.05, and so on until 0.02. Each grade of flow is connected, and it is the only one that does not have an oxygen blender because it contains automatic devices. You can adjust the FiO2 according to the flow you are using, starting from 0.8 liters for each level. This allows you to set the FiO2 to about 55%, which is a high percentage, and then you use the adjustment. Each flow level has a fixed corresponding FiO2 value. You cannot change it. Why do I use this option? Because I use it for the doctor who does not need to decrease, but actually needs to decrease. And this is evident with medical professionals such as doctors who have patients with chronic lung conditions. Those with chronic lung patients will want to decrease quickly, so you start with the vapotherm. After that, when the patient reaches 1 liter, you can decrease further because the microflow uses less than 1 liter, so this patient still needs oxygen for that reason. The microflow provides FiO2, and then you gradually decrease it until the patient is stable. I'll say a short and simple word about the CPAP machine. We need to get used to pronouncing its name correctly. And we talked about it a bit in detail. But for convenience, and as is common among people, they call it that. There's no problem if you say CPAP machine, even if you call it CPAP machine. But you should know that it's actually called CPAP machine. And please remember that CPAP is not a machine. CPAP is a mechanism. What does mechanism mean? CPAP stands for continuous positive airway pressure. It means you provide the patient with a single level of pressure, and that single level is called CPAP. Someone might be wondering, what's the difference between CPAP as a mechanism and PEEP? Because someone could say, I'll just give him PEEP. So, do you really actually understand the difference between the two? We said that PEEP is positive end expiratory pressure, which is important to remember. You might understand what PEEP is and what CPAP is. PEEP is the natural one. There is a range of mobility in patients, and for all of us, this is the range of mobility. The natural range of mobility is something we all have or we all possess. Continuous mobility exists in the respiratory area. When I provide support to the patient, I provide support with CPAP, and it is an independent level for the patient, and it is an independent level for the PEEP. This means that he can exclude the PEEP, meaning it is independent for him. But it must be higher, so he can exclude the PEEP. That's why they are close to each other. But the PEEP is the independent level for the patient that the patient has, while the CPAP is the independent level for the patient that allows the patient to exclude the patient completely from breathing. I hope this point is clear. There is something very important between the CPAP machine and the BiPAP machine. The CPAP machine, because we said we have 3 very well-known devices, the CPAP, the BiPAP, and the ventilator. But the ventilator is used in a different way. A very important question will come up. Is there a difference between the CPAP machine and the BiPAP machine? So can I use either a CPAP or a BiPAP or even a ventilator for any patient? Of course, there is a difference. The difference is, first, let's just understand a little bit about each machine. The CPAP machine is a device that we use only in the unit, and it is a machine. In fact, it's very unique because ever since it was created, it has looked exactly like what you see now. And then it has a very important characteristic, which is the PEEP. So if you use it to provide PEEP, it has that feature. The PEEP, however, has a maximum of 10. What does maximum mean? It means that if I want to give the patient CPAP, I can set it to 5, 6, 7, or 8. As you like, and this is usually the regular mechanism that we want. The regular level, usually we use 6, 7, or 8, and some people use 9. But if you want to convert this machine from monophasic, which is 1 level, and in the second area, you will use another level, which is the BiPAP, also known as bilevel positive airway pressure. BiPAP is generally supposed to be considered the natural one as well. It's the peak inspiratory pressure that the patient experiences when they're taking intermittent pressure, which is a key aspect of respiratory support. This pressure is called PEEP, which stands for positive end expiratory pressure. When I provide them with another level of support, meaning two distinct levels, PEEP and PEEP, the maximum value I can set this PEEP to is 10, and that's actually considered a relatively low number in clinical practice. This brings us to an important point. With these different ventilatory modes, such as NIV, which stands for non-invasive ventilation, we use them from the ventilator, but the reality is that we consider these modes, when they have two levels, to have only two levels of support. We can't simply say this is PEEP because when you set the mode to PEEP 10, for example, this isn't technically considered PEEP in the traditional sense. The patient can have what we call natural PEEP. They can generate PEEP themselves during inspiration, and they might even reach more than 10. That's probably the reason why we don't consider this as intermittent ventilation. Instead, we consider it as two levels of support, like two PEEPs. For example, if you set one to 6 and the other to 10, they're just two levels of PEEP, each providing a different amount of support. But in the end, what's the benefit of this approach? It increases the mean airway pressure. It improves the mean airway pressure for the patient, raising it a bit, which can be beneficial in certain clinical scenarios. But in reality, and from a scientific perspective, we can't say this is intermittent support, like PEEP and PEEP, but we can consider it as two PEEPs, one at 6 and the other at 10. So the ventilator specializes in being able to deliver air anywhere within the respiratory system, adapting to the patient's needs and providing the necessary support for optimal breathing. We'll talk about these numbers next time, but before we do, it's important to keep in mind that CPAP and BiPAP simply provide two different levels of PEEP, or positive end expiratory pressure. So another important point to note is that the BiPAP machine is used exclusively in pediatric patients. We don't use it in neonates except in very rare and exceptional cases. When a neonate grows older and becomes, for example, around 6 months old, there are situations where they're still in the NICU, the Neonatal Intensive Care Unit. So we have to give them BiPAP at that point because they've transitioned from being classified as a neonate to being considered a pediatric patient, and then we can use it safely and appropriately. So in actual clinical practice, we only use the BiPAP machine in pediatrics, and the maximum support we provide is a pressure support of up to 20. Now, let's talk about something very important. We need to know and understand what the interface is. We need to understand that there is something called the machine. Whatever type of machine it is, it provides respiratory support and creates a type of support. This support could be flow or pressure, and as we said, flow could be one level, or it could be bi-level, meaning there could be one level or a second level for the users. So what is the story with the interface? The interface is the part that you place on the patient, the part that delivers the experience to the patient and connects it to the problem. It comes in different shapes and forms. All right, first, there are two types. One is a mask, which is a regular mask, and the other is a prong, meaning it's a nasal prong. This means that there is a small group who use the nasal prong, which goes a little bit inside even the prong itself. This one tends to be a bit longer, mainly because it really depends on exactly what you're doing at the time. And sometimes there can be quite a lot of switching back and forth between the mask and the prong. But in the end, to sum everything up, the mask is generally better overall. That's it. But there's another important point about the prong. When the patient can't use the mask, you can use the prong instead. So at the beginning, if there's nothing else, what can we use? This is not related to the machines. You can use the CPAP and attach to it an interface. Whether it's a mask or a prong, you can use the BiPAP and you can use the ventilator, and you can use either the mask or the prong. The interface part is separate from the machines. You can use different interfaces with different machines. Now this brings us to an important question. What's the story with the RAM cannula that we hear about so much? In the NICU or in pediatrics, you'll find something called the RAM cannula. They say, give him CPAP with the RAM cannula, or give him BiPAP with the RAM cannula. What's the story with this RAM cannula? This is a question that comes up quite often, and it's understandable because the RAM cannula tends to confuse a lot of people, even those with experience in the medical field. Many people aren't entirely sure how it works or why it's used, which can make it seem more complicated than it really is. But in fact, the concept behind the RAM cannula is actually quite simple once you understand the reasoning behind it. The idea for the RAM cannula came from noticing that some patients, especially those who are a bit chubby or overweight, often have difficulty tolerating the standard mask used for non-invasive ventilation. The mask is a fairly large device that needs to stay on the patient's face continuously, sometimes for many hours at a time, in order to be effective. This constant use can be uncomfortable, and for some patients, it becomes intolerable. The pressure from the mask, the sensation of being enclosed, and the need to keep it on all the time can lead to significant discomfort and even anxiety. In addition, using the mask for long periods isn't always good for the patient. It can cause problems such as pneumothorax, which is when air leaks into the space between the lung and chest wall, potentially causing the lung to collapse. Another issue is that if the mask isn't sealed properly, it can interfere with the patient's ability to breathe in inspiration or breathe out expiration. In some cases, the mask can even have the opposite effect of what we want, leading to complications that can make the patient's condition worse instead of better. So what can we do in these situations? One solution is to use a RAM cannula. It's important to clarify that when we say RAM, we're not talking about computer memory, but rather a specific type of nasal cannula. The RAM cannula looks similar to the regular nasal cannula that many people are familiar with, but it's designed to be used in a different way. The main idea is to connect the RAM cannula to the system that delivers respiratory support, allowing us to provide the necessary assistance to the patient without the need for a bulky, uncomfortable mask. This approach can make a significant difference for patients who have trouble tolerating masks, offering them a more comfortable and effective way to receive the care they need. The ventilator that delivers non-invasive support is called by its specific name, which is RAM. You'll find that this is actually an abbreviation for the name Ramathan. Ramathan is an American doctor of Indian origin, and you can find more information about him if you search for him on Google. We're mentioning this detail so that we all understand and don't just say RAM without knowing what it is or where it comes from. Some people mistakenly think the company is called RAM, or that it's just a random name, but to give credit where it's due, we're clarifying this point. The details here help us understand something very important. If you go now and see someone using a CPAP machine, a BiPAP device, or a ventilator, and you see them using a nasal mask, you'll notice something different. Even the application is different. The two tubes you see with the nasal mask aren't present in patients who are using a nasal cannula. If you look at patients using a nasal cannula, whether it's size 2, 3, 4, or any size at all, you'll see the nasal cannula is inserted into the patient. This is very important because for patients using a nasal cannula, instead of completely sealing the nostril, the cannula should be about 50% of the diameter of the nostril opening. This way, we leave space for exhalation. The cannula delivers inspiration, and the patient can exhale on their own. If we seal it completely, there won't be any chance for exhalation. This doesn't happen with the nasal mask. If you look at the nasal mask, you'll see it needs to be tightly sealed, with no leaks or air escaping. Why? Well, the reason is that the nasal mask is designed to create a closed system, ensuring that the air pressure is maintained and that the therapy is effective. With a nasal mask, any leaks can reduce the effectiveness of the treatment, so it's crucial to have a proper seal. In contrast, the nasal cannula is intentionally designed to allow some space for exhalation, as we discussed earlier. This difference in design and application is essential to understand when working with different types of respiratory support devices. So, always remember to check the fit and application of these devices carefully, as it can make a significant difference in patient outcomes. Because the two tubes that go into it, one delivers inspiration and the other takes away expiration. So it's very important for it to be sealed. But with the nasal cannula, it's crucial that it isn't completely sealed. It should be maximally open. What does 50% mean? It means that if you use the RAM cannula to deliver pressure and we connect it to CPAP or BiPAP, you should know that the pressure reaching the patient is not the same as the pressure set on the machine. If you set the CPAP to 6, it's not actually 6 that's reaching the patient because of the leak. So you have to allow for this to create a pressure, and then it will reach the patient. It will be less than 6, and it could be 5 or 4. So when we use the RAM cannula, if we want to deliver 6, we should set it to 7, because there will be a leak and the pressure will be lower. I hope this topic is clear and that you listen to it again and understand it so we can be able to recognize this issue. When using the RAM cannula might be set to 6, but in reality, it could be delivering 5, or you might use a RAM cannula set to 7. And the RAM cannula could be at 6. So if you have patients, you might give them a mask at 6, and then you find the patients are still unwell, and you need to switch to a RAM cannula, you can do that. If you were giving 6 with the mask, make it 7 with the RAM cannula to achieve a higher effect because there will be a leak around the prongs. That was today's topic from the 3rd episode of the respiratory support series. Next time, we will talk about something very important called bubble CPAP, and we will also discuss some very important things in physiology. We will talk about curves. This is extremely important, which is the relationship between pressure and volume, known as the volume-pressure loop. This is one of the important things we want to understand, and we will also talk about something else that is very important. It is something known as the respiratory function test, which is also sometimes referred to as a pulmonary function test. We need to understand exactly what it is and how it works, because it has a very significant and important role in the applied project that we are currently working on. That was today's topic. I hope it was useful, and I hope we can share this with our friends in the NICU, in pediatrics, in the PICU, and in the P world. Everywhere. Thank you. Peace be upon you, and God's mercy and blessings.